Good morning. Myself, Mariya M Jos of Coorg Institute of Dental Sciences, Virajpet, Karnataka, India. I am honored to get this opportunity to present a case report where three-dimensional visual treatment objective aided in treatment planning and patient education. Moving on to the case report, we'll take a tour through the introduction, chief complaint, clinical examination, radiography, diagnosis, treatment plan, VTO, surgical phase, results and conclusion. A 24-year-old female patient reported to the department with the chief complaint of unaesthetic smile. The patient was concerned about forwardly positioned lower jaw. Clinical characteristics. On extraoral examination, the patient had a symmetrical leptoprosopic face with a concave profile, prominent chin, deficient midface, flat cheekbone contour and positive lip step. Intraoral examination showed Angle's class 3 type 3 malocclusion, overjet of negative 1 mm and a crossbite with respect to 1-2 and 2-1. The maxillary and mandibular arches were well aligned with slight crowding in the mandibular arch with all permanent teeth present and good oral hygiene maintained. On cephalometric analysis, the patient is skeletal class 3 due to mandibular prognathism, retroposition maxilla, upper incisor proclination, and lower dental retroclination produced by physiological compensation. Diagnosis. The patient is skeletal class 3 due to maxillary deficiency, prognathic mandible. The patient showed Angle's class 3 molar relation bilaterally. The problems to be addressed include concave profile, skeletal class 3 malocclusion, Angle's class 3 molar relation bilaterally, and a reverse overjet of 1 mm. We'll look into the treatment planning now. One of the greatest challenges in orthodontics is the treatment planning to achieve a well-balanced occlusion, proper function, and harmonious facial aesthetics. We should always start with the end in mind. The orthodontic treatment planning is three-dimensional. It involves three planes: the lateral view by lateral cephalometry, frontal view by anterior-posterior cephalometry, and the occlusal view by occlusiogram. The severity of skeletal class 3 malocclusion may affect the facial aesthetics to the extent that orthodontics alone may not be the treatment. In such cases, an ortho-surgical treatment is necessary to provide satisfactory results. For our patient, the treatment was planned in 3 stages: pre-surgical, surgical, and post-surgical orthodontics. And here is when we encountered the real challenge. The patient is scared to undergo surgical procedures and is worried about her facial appearance. A conventional VTO and cephalometric tracings were used to educate the patient. It was not effective in convincing the patient, rather she was even more confused. And that's how our thoughts landed the possibility of a personalized three-dimensional visual treatment simulation, VTO. VTO is a treatment planning and communication aid. It helps us predict hard and soft tissue changes that may occur by surgery or by the use of a functional appliance. It also helps in communication with surgeons in orthodontic cases. It helps in growth forecast and patient education and motivation. The threefold functions of 3D VTO. Firstly, to establish the pre-surgical orthodontic goals, to develop an accurate surgical objective that achieves the best functional and aesthetic results, and to create a facial profile objective that acts as a visual aid in consultation. A picture is worth 1,000 words, and this is the pre-treatment VTO created for our patient to help in patient education and motivation. We say beauty lies in the eyes of the beholder, and aesthetics is very subjective. Many times, orthodontists may have a different perspective from the surgeon. Aesthetics that both the orthodontist and the surgeon agrees on may not be what the patient has in mind. Ultimately, patient is the king, and their opinions must be valued and accepted as long as it doesn't compromise on form and function. We used this VTO to help the patient understand the changes that can be made and set realistic expectations. Back to the case history. Pre-treatment lateral cephalogram was digitalized and evaluated on Dolphin software. The pre-treatment photograph was superimposed on the lateral cephalogram. Treatment simulation was done with 4 mm anterior sagittal movement of maxilla and 7 mm mandibular setback. After lip repositioning, the profile was found to be satisfactory. A multidisciplinary team approach is inevitable when recommending surgery for a patient. Here, the treatment was carried out in three stages: pre-surgical, surgical, and post-surgical orthodontics. Pre-surgical orthodontic phase. After initial assessment, the pre-surgical phase was initiated with the goal of achieving arch coordination. The decompensation of maxillary and mandibular arches were done to gain a negative overjet by extraction of 1/4 and 2/4. The pre-surgical features show the performed decompensation for the surgery. Moving on to the surgical procedure, a bimaxillary surgery with maxillary advancement of 3 mm and mandibular setback of 7 mm after pre-surgical decompensation of the arches were performed. In the mandible, a bilateral sagittal split osteotomy was conducted for mandibular setback, and Leaford 1 was performed for maxillary advancement. Rigid fixation was placed in the maxilla through the use of 4-hole mini plates and a screw on both sides. An intermediate splint was used to secure the mandible in correct position. Intermaxillary elastics were used for 30 days during the immediate post-operative period to achieve maximum stability. Post-surgical orthodontic phase. Active orthodontic treatment was resumed 4 weeks after surgery. The objective was to achieve ideal occlusal relationship in terms of canine and molar relationship, overjet and overbite, and matching dental midlines. During post-surgical orthodontics, 1925 SS arch wires were maintained. All the residual spaces were closed, and intercuspation was refined with 1925 braided arch wires and short intermaxillary elastics. Post-treatment, the patient had ideal overjet and overbite of 2 mm and concordant midlines. The case was finished in Class 2 molar relation, Class 1 canine relation, and canine guided occlusion. It is important to highlight that a good retention helps maintain the final occlusion that is achieved surgically and a long-term occlusal stability. The patient was extremely happy with her new smile and aesthetics, and this gives us a boost to create more beautiful smiles and pretty faces. Thank you.